Doctor. Good morning. Good morning. Just like to say I was honored to be asked to be on this panel because we have been quoting Dr. Sandel for a long time, but I never heard her speak in person. And also you have to know when Joan asks you to do something, the only answer is yes. Really a leader in our community development field, and so I really appreciate the opportunity. So my story today is going to attempt to answer the question, why would a hospital invest $3 million in a nonprofit to build housing? That's our story in Burlington, Vermont, with our University of Vermont Medical Center. And as I describe this story and how we've evolved together, I think there's three characteristics really important. One is collaboration, the other is innovation, the third is evaluation, because evaluation is not only your proof of concept, but it also is an engine that drives you to improve what you did, to prove what you did, and to go on to do the next thing. So ours definitely did evolve into from one project to another. So first, I'm going to give you just a thumbnail of how Champlain Housing Trust got into this area very briefly, and then I want to describe specifically the three projects that we've done with the hospital and the related work that is around that. We are doing this in the context of a strong community-wide collaboration to really address homelessness in our region, but I'm going to focus on that as our topic. And then at the end, just review the sources the hospital used and their motivations, and I think some of that will come clear, but just I was asked to really look at where the dollars came from. Our focus in this area for Champlain was about deepening our engagement to solve homelessness in our region. We've always served the homeless as part of we call our 2,900 homes a continuum of housing from homeless to homeownership. But really, in 2013, we were doing a strategic plan in reaching out to the community and also to our own staff. What we heard again and again was you need to step in and do more and differently in the homelessness space, because in Vermont, from the time of the crash till 2013, homelessness went up year after year after year. By 2013, we had a crisis. Our shelters were full. The state did not know how to cope with this. It was a broad impact, and we realized, while we'd always said we do the permanent housing and help other providers do this, they obviously need us to step in. And some of the things we could bring to it, obviously, as developers and folks who've managed a lot of housing finance, maybe the capacity to build, to add to it. So our participation in this has been both on and in our strategic plan, change in our practices and some programs. We've added programs and policies to deal with the folks that we're serving being much more fragile and needing to bring more promptly into our housing and then help them succeed there, which, as you can imagine, includes social work, more financial counseling, a range of things. But the other part of it was production. And we set a strategic plan goal of 40 new homes for people who are experiencing chronic homelessness, and 30 new homes for families. And then we do, in this collaborative, we do a coordinated point of entry where we identify the most vulnerable, and Champlain Housing Trust prioritizes homeless folks for our vacant apartments. We've also set aside unrestricted apartments. For example, last year we housed 85 households right out of homelessness, and we only get about, in this part of the city, of our region, about 130 vacancies a year. So we really have prioritized that, and it's working well for us. It's very, very important. We just started a new strategic plan where we actually really decided we just have to double down, that we're seeing the impact we're having, but we need to do more. Over the 3 years since 2013, not just for us, but for this concerted effort, we have actually finally reduced homelessness by 41%. It started to go down in 2015, and each year we continue to bend that curve. And I wanted to thank Dr. Sandel for two particular things. Her emphasis on that words matter, and I want to note that Dr. Sandel says home, not housing units, and I encourage you all in your work to just stop saying housing units. Nobody lives in a unit except the poor when we say that, and I think that that's very valuable. Also want to thank you for addressing the equity issue, because it really comes down to that. So now to focus on the 3 projects that we did do with the University Medical Center. Harbor Place, which is an emergency housing option, which we operate to this day, and then 2 permanent housing developments. They're small. This is Vermont, Beacon Apartments and Bel Air Apartments. So Harbor Place is where we first started to partner on housing. This is the state was under a lot of criticism for vouchering homeless people to motels. The shelters were always full. We have a cold weather exception in the winter, but the expense was just shocking everybody and gone well over budget. And so we thought for the first thing we could do with our skills and capacity is buy a motel and do it better. So we bought a 59-room Econo Lodge, which is pretty sizable, again, in our region. And then the state funded us in a different way. Instead, we said, we can't just wait for you to voucher people. They gave us some capital. They also committed to a block of rooms, so we knew we could operate the property. We didn't use a lot of the traditional housing sources. We got a community loan fund, their big loan, and then we got grants from their United Way and many partners, including a related foundation to the hospital. But what we also secured with the hospital is a contract, because they were putting people up who were homeless, who were getting outpatient treatment at the hospital in a range of motels. So they agreed to an exclusive contract with us, so we could count on those rooms going to the hospital. And I'm sad to say that Harbor Place continues to be full almost year-round. Last year we served 600 households. It's pretty typical. So we have now added things like community gardens and a playground, and because many families are there in the larger apartments. We also have a contract with the folks helping people fleeing domestic abuse. But the second thing we did for the state was we brought services on site. And again, we didn't create these. We asked our partners to come and have office hours on site, so that when people get a room at our lodging, they also get services attached. So after 2 years, we studied the results, did an evaluation, and people in this motel were 5 times more likely to be rehoused into permanent housing as a result of that combination with services, and 9 times more likely to be connected to services, because just getting put in a motel for a few nights and was not helping people access service. But the University Medical Center decided to study what was the impact on the people they served there, and they had served 95 people there in 2 years, and this is what they learned. As a result of staying there, these folks had reduced emergency room visits by 41%, and use of other hospital services by 81%, saving the hospital $1 million over 2 years. And also after that same period, the state saved $1 million in reduced lodging costs. And that's before you count up our better outcomes. So with the hospital, we talked about what is the next thing. And we knew if we did this housing, we would see what were the particular kinds of transitional, perhaps, or other kinds of housing missing in our continuum. And we saw the need for permanent housing for chronically homeless folks. There were not enough apartments for us to move people in, and some needed more help. When you go on the chart of our coordinated point of entry for the most vulnerable homeless, these are people who are chronically ill and chronically homeless. So we bought another little motel. We call it Beacon Apartments, and it's 19 micro homes, little apartments. And there's health care services on site. And here, the University Medical Center funds the health care services on site, but very interestingly, and they've always done this, they don't fund this to do this directly. They fund our community health center, who has a best practice ward-level program of working with the homeless and with the chronically homeless. They call it Safe Harbor. And I feel they are the experts, along with the people in our ER, on who's out there and what they need. And so they're funding them at our site. Here we used not too many traditional sources either. We always do seller financing on these, which helps us acquire them more quickly. We got Section 8 vouchers for the folks which are portable, so they can stay here permanently, but if in 2 years they want to move, they get to take that subsidy with them. It's a brilliant piece, increasing that, no barriers, increasing that opportunity. We raised some grants towards construction. Okay. In this time period, there are two things are happening. One is the UVM decided to study also the folks that were being housed throughout the portfolios through this coordinated point of entry. So the idea was we were serving the most vulnerable first. So the first 32 people who were housed, they evaluated and found that over 1 year, the reduced medical service cost for them was $14,300 each, or over the 32, almost $500,000 in savings. And this is an interesting measure in terms of health and housing, because, you know, the other group had very dramatic declines, but of course they had presented as ill, right? They went to the hospital, they're getting treatment. They should use the hospital less after. This is purely how people were needing health care before and after. So I come to our current project. It's called the Bel Air, also another small motel. You can see what's happening to the motel stock in our region. It's always available for sale because you know that economic model's gone. They're the old-fashioned motels. So we're about to open this. And this will serve 12 residents, 4 in a congregate setting who can't quite make it on their own but are not nursing care, neither, not nursing level. And then 8 apartments, very much like Beacon. With the permanent and portable vouchers. Now, this project is to serve people who are housed at the hospital because there's nowhere else for them to go. The most expensive housing, as we mentioned. And this is the project that is fully funded by the hospital. What happened before Bel Air is that the hospitals determined they're going to give us $3 million to just keep doing housing because it had such a direct benefit for them. And we had been talking to the hospital in this relationship. This was over a couple of years. We had presented investment scenarios to the hospital. We have a fund we call LIFT, where we're getting program-related investments from, for example, our state treasurer, our community foundation, and others to help us, leverage equity to build or to repair and acquire housing. And we thought with the hospital, what a great fit to do housing with them. And these conversations were ongoing. I have to tell you, we found leadership in the hospital that were willing to take our case to, as you said, there's these different boards and departments. So we had that leadership. What happened in the meantime is in 2015, the hospital exceeded its revenue projections. And in Vermont, the hospitals are regulated by the Green Mountain Care Board, which is also pushing them to community-level health and all the things that you talked about that are moving health care in this direction. And the requirement, if you have excess revenue, is you have to bring a plan to the Green Mountain Care Board to show how you're going to address community-level health, and most of it needs to be returned to the state to lower health insurance costs. So the hospital announced a plan where they gave smaller amounts than this to other organizations to address things like opiate addiction and food and a variety of things, and $3 million to us for housing. So it became controversial that they just decided to plunk so much money in housing. It was a first, and some of our leadership in the legislature really opposed it, but the Green Mountain Care Board came through and said, the proof is there, this is what they should be doing. So that was very, very exciting. And we continue our conversations with the hospital. They are sitting on these enormous investments in capital, and I think that we can move in that direction for the next. But, they're going to wait. We're going to evaluate what happens at these to move on. So finally, I think you see their motivation. I would also say the Chief Medical Officer, Dr. Leffler, he works in the ER. He knows these folks were serving himself. And what you said about the political capital of the hospital, they've also come through as advocates for the poor and advocates for housing, and it's a tremendous, tremendous relationship. So finally, I just want to say, if you have a few minutes sometime, go to our website, getahome.org, and under programs, there's a healthcare and housing section, and you can find a little video. It's only like 8 minutes, but you will meet all the partners, some of the residents and the doctors that have been involved in these 3 developments. Thank you very much.